Hey everybody, Dr. Rob Silverman here, author of Inside Out Health and ACA Sports Council Chiropractic of the Year 2015. And I want to talk about fixing the foot from the toe to the heel. And I want to emphasize one thing in particular. I want to talk about something that 10 million Americans have, and that's called plantar fasciitis. So the huge takeaway during this next 8 to 10 minute demo is that idea of plantar fasciitis being muscle is sort of antiquated. It is 70 to 75% having some nerve involvement. So with that being said, I want to show you how to utilize and diagnose the different nerves. So when we look at the nerves, obviously we all know they come from our back through the lumbar plexus. One nerve in particular called the tibial nerve, a branch off the sciatic nerve, goes down behind the knee and goes all the way down to the inside of your foot. So it goes right to the tarsal tunnel. So I want to take a look and show you guys how to evaluate the tarsal tunnel. Because if you have tarsal tunnel syndrome, that's 50% of what's going to mimic what most people call plantar fasciitis. I've got my friend right here, and he's going to lay on his back, take your right shoe off so we can get at that. And you know what? Yep, that'll work great. So have a seat right there. You can take the sock off too, that'd be great. So he's laying down in a supine position. So everybody knows what a straight leg raise is, I'm sure. So I always, for me, we're gonna say his left side is implicated. He's complaining of pain right here. So I'm gonna lift up his right leg, and it goes up, and his right leg's pretty good. We call that a well leg raise. Then we're gonna go to his left leg. It's gonna lift up, and his left leg's gonna get a little tight. So we realize that he has a little implication that he doesn't have the same type of movement. Now we're going to do what we call a neurotension test. When I dorsiflex the foot, I'm pulling a tremendous amount of pressure below the knee on what we call the tibial nerve. So he'll go up, and typically he'll say in a shorter distance or decreased range of motion, ow, it hurts. So we're looking at this tunnel as the tibial nerve comes through this tunnel. So there's different looks that we can check out in that. Here we go. So I'll open up the tarsal tunnel, and when I pull on it, he'll feel that nerve. So he'll give me that, ow, it hurts. I can go in there and palpate. 50% is caught here, and there's a little branch that goes through there. So while she has the camera right there, that little branch off the tarsal tunnel is called the lateral plantar nerve. It comes right through here. We're going to test that in a little while. If that is caught, that's called Baxter's neuropathy. So while she's right there and they feed her up, if I'm going to look at Baxter's neuropathy, I'm going to ask him if he can splay his fifth toe out. And he can. So if he can splay his big toe out, the adductor digiti minimi is working. There's a motor component of that nerve to that muscle. If he couldn't, and it was like that, it may imply that he has Baxter's neuropathy, pain right there. Another way to do it is to bring up, dorsiflex, and abduct his foot. So I would hold that for 30 seconds. That would cause an ischemia to the nerve. And if he feels the ischemia in the nerve in here going through here, and that stimulates the pain, he has Baxter's neuropathy. Approximately 50% of the people have the nerve caught here, and 20 to 25% have the people caught there, that being that branch. So it's really only 25% of the muscles in this range, and most people think it is. So if it's true plantar fasciitis, which I'll show you a test for in a moment, I'll show you something that you can use to not roll it. I could roll it. I could be a doctor who rolls it. Look at that. Isn't that pretty easy, and that's nice? Or if you would you stand up and show everybody what you can do to help out that foot? So now that he's rolling it, I'm going to come down, I'm going to scoot down, I'm going to take that out. I'm going to put his foot into neutral, his ankle into neutral, hold him in neutral, and pull up on his big toe. If I pull up on his big toe and he goes out, that's true plantar fasciitis. So we've got the three tests. You've got the neurogenic test to see if the tibial nerve is caught in the tarsal tunnel. You've got the two tests testing the abductor digiti minimi muscle in the foot where he splays. You also have where you have the ischemia and reperfusion in the area over here. And then you have your true plantar fascia test. So what's most interesting about this is we're finding out with the tarsal tunnel issues that people usually have what they call a lower extremity double crush. We've heard of upper extremity double crush with the carpal tunnel and up by the brachial plexus. You're also going to find that very, very common in the lower limb. So I'm a big proponent, even though you have something in the lower extremity, look up the kinetic chain to see what kind of involvement you have in the sacral plexus, something off the sciatic nerve. So he who treats the site of pain in musculoskeletal is lost. So always look up the kinetic chain. Now, he has an issue with plantar fasciitis. He obviously has a lower kinetic chain issue, and one of the biggest things you always want to correct in any patient is what we call altered motor control. Altered motor control is an inappropriate type of proprioception. So his proprioception is his ability to see himself and feel his awareness in space. It's a harmony between the nervous system and the muscular system. There's so many afferent mechanoreceptors in the bottom of the foot. He's going to have a tremendous amount of issues with plantar fasciitis getting over the issue if you don't correct altered motor control. One of the best ways to correct altered motor control is to involve a stability pad. So what I would do first is I would show him how to short the foot. So essentially he's going to push his toes down and his heels down. I'm going to get my hand in here. He's going to elevate his medial longitudinal arch, because that heel pressing in is one of the highest spaces or parts of the body that has mechanoreceptors. So now he has what we'd like to refer to as a yonder short foot. I've got that in there. That's beautiful. So what I'm going to do is I'm going to introduce the Thera-Band Stability Pad. I'm going to put it down. I'm going to ask him to put his foot on that, and I'm going to ask him to short the foot. I'm going to ask him to stand here, and then I'm going to ask him to lift his right foot up to get more of an instability, so he increases his proprioceptive feed. Now, he's pretty good. I could do some patuberations, and see, once I did the patuberations, he gave. So we want to get to a level after this plantar fasciitis to be able to allow him to stand on one foot and on one foot on the stability pad. A couple of FYIs with plantar fasciitis. My typical scenario, if it's an acute plantar fasciitis and it's nerve, it's more of a 6 to 8 visit. You should see 50% improvement or more. Definitely look at the nerve in the back of the heel. Definitely look at the nerve at the tarsal tunnel, and go up to the calf and look for one of the branches to see if you have a mimicker. Look at the body from top to bottom, always bottom to top. Plantar fasciitis is a very common ailment that I found out has been misdiagnosed. So good luck on assessing the toe to the heel. Dr. Rob, always yours in health.